Dengue fever, also known as breakbone fever, is an infectious tropical disease caused by the dengue virus. Symptoms include fever, headache, muscle and joint pains, and a characteristic skin rash that is similar to measles. In a small proportion of cases, the disease develops into the life-threatening dengue hemorrhagic fever, resulting in bleeding, low levels of blood platelets, and blood plasma leakage, or into dengue shock syndrome, where dangerously low blood pressure occurs. The mortality is 1–5% without treatment, and less than 1% with adequate treatment. However, severe disease carries a mortality of 26%. It infects 50 to 100 million people worldwide a year, leading to 500,000 hospitalizations and approximately 12,500 25,000 deaths. Dengue is endemic in more than 110 countries. Forms of infection occur in the countries of Southeast Asia, Oceania, and in West Africa. The causative agent is the dengue virus of the genus Flavivirus, the family Viridae. The source of infection in the urban fossa are human patients and in the sylvan fossa monkeys. The source of infection is dangerous during the first 5 days of the disease, viremia. The infection is transmitted by female mosquitoes of the genus Aedes and others that become contagious in 8 to 12 days after sucking blood of an infected subject. Contagiosity persists for the entire life, 3–4 months. Children and travelers are mostly affected by the disease in endemic fossa. The virus is inoculated into the human being by the bite of an infected mosquito. The virus multiplies in the cells of mononuclear phagocytic system for 5–16 days, and is then carried by the bloodstream to the central nervous system, kidneys, liver, muscles, and other organs and tissues, where the virus propagates and is again carried by the blood to cause secondary wave of fever. Since the vessels are involved, the hemorrhagic syndrome develops. Hypovolemia develops. The incubation period lasts from 8 to 15 days. The onset of the disease is usually acute. It begins with a shaking chill and rapid elevation of temperature to 39–41. High temperature persists for 3–4 days. Headache, myalgia, and arthralgia develop. The patient feels pain when pressure is applied to the eyeballs. Photophobia, perverted taste, nausea, vomiting, and diffuse abdominal pain are characteristic. The patient is stretched in his bed because of severe muscular and joint pains. Gait becomes slow and tense because of restricted movement of the joints, especially in the knees. The patient's face is edematous, the forehead and cheeks are hyperemic. The gaze is glossy, scleral injection is marked, punctured rash appears on the second or third day on the trunk, chest, and abdomen, then on the face and extremities. On the 4th or 5th day it looks like in scarlet fever or measles. Less frequently it is petechial. The first 2 days are characterized by tachycardia, which is then followed by bradycardia. Arterial pressure is low. On the 3rd or 4th day of the disease, oliguria and even anuria develop. Azotemia is present. The temperature curve has usually one wave. If the disease has 2 waves, the temperature falls by crisis on the 3rd or 4th day. Profuse sweating follows. After first 4th afebrile day, the body temperature rises again and persists for 2-3 days. The second phase of fever is milder. The overall duration of the fever period is 5-9 days. The recovery phase is prolonged up to 2 months. It's marked by astheno-vegetative symptoms, arthralgia, and decreased walking capacity. Hematologic shifts in the early stage of the disease are normocytosis with a relative neutrophiliosis. During later period, leukopenia and relative lymphocytosis. The diagnosis is established on the basis of clinical, epidemiologic, and laboratory findings. The virus can be detected during the first, second, third days of the disease. To this end, suckling albino mice are infected into the brain. Serologic tests with the paired serums are used on the 5th, 6th day and later. Treatment is symptomatic and pathogenetic. Prevention and control. The main measures are aimed at disruption of the transmission routes in the endemic foci. They include destruction of the mosquito vector and the larva, individual protection of people from mosquito bites using repellents, screening and netting. Special care should be taken to protect patients from mosquito bites, since they are the source of infection. Phlebotomous fever. Papatachi fever, also known as phlebotomous fever, is a vector-borne febrile arboviral infection caused by 3 serotypes of Flavivirus. Papatachi fever is prevalent in the subtropical zone of the Eastern Hemisphere, particularly in the southern Europe, North Africa, the Balkans, Eastern Mediterranean, Iraq, Iran, Pakistan, Afghanistan, and India. It breaks out in epidemic form during the summer season following sandfly breeding. Hosts may include warm and cold-blooded vertebrates and possibly plants and shrubs. The disease is transmitted by the bites of phlebotomine sandflies of the genus Phlebotomus. The sandfly becomes infected when biting an infected human in the period between 48 hours before the onset of fever and 24 hours after the end of the fever, and remains infected for its lifetime. Besides his horizontal virus transmission from man to sandfly, the virus can be transmitted in insects transoverally from an infected female sandfly to its offspring. In human hosts, the virus multiplies and becomes widely disseminated throughout the body. A few days after the infective bite, a feeling of lassitude, abdominal distress, and chills develop, followed by a fever of 39 to 40, severe frontal headache and postorbital pain, muscle and joint aches, flushing of the face, and tachycardia. Usually after 2 days the temperature slowly returns to normal, only rarely is there a second episode of fever. Following the febrile period, there is great fatigue and weakness, accompanied by slow pulse and frequently subnormal blood pressure. Convalescence may require a few days to several weeks, but the prognosis is always favorable. Diagnosis be confirmed by serology-based assays or real-time PCR. There is no specific treatment for the disease. Prevention of sandfly bites and control of sandflies and their breeding grounds with insecticides are the principal methods for prevention. Mosquito nets may not be sufficient to prevent sandfly bites.